discuss about diuretics. So diuretics is there are so many drugs in diuretics. I'll just explain the mechanisms for today, pathophysiology and all, and I'll explain the dose and antidiuretic hormones and all in the next step. Okay. So diuretics, what is diuretics? It helps in the elimination of sodium, chlorine and water. That in total it increases the urine output. Okay. So this is the nephron. This is the filtering unit of glomerulus, the filtering unit of kidney. Okay. So here what is going on is this is the glomerulus, and filtered sodium and water is going through the renal tubules. Okay. So sodium and water is filtered in the glomerular capsule of nephron, then reabsorbed back to the blood at various sites along the renal tubules. So different diuretics, there are some different diuretics, I'll explain slowly, and this diuretics prevents the sodium reabsorption in various sites of the this renal tubules, nephron, in total nephron. So by that it increases the loss of sodium in the urine. Okay. So let's start with carbonic anhydrase inhibitors. So this part is the early proximal tubule. So this part reabsorbs the sodium around 65 to 70%. So for this the carbonic anhydrase inhibitors acts in the proximal tubule. Okay. So carbonic anhydrase inhibitors, the drugs that is included in the carbonic anhydrase inhibitors are acetazolamide, dichlorphenamide and methazolamide, and there is furthermore. So site of action is the proximal tubule, this part. Okay. Early proximal tubule, like complete, it will act on the proximal tubule. So mechanism is inhibitor of bicarbonate reabsorption. Okay. So inhibits the enzyme carbonic anhydrase, which is required for reabsorption of bicarbonate in the proximal tubule, as I said earlier, and it leads to the greater loss of sodium. Okay, in the form of urine. And in the form of sodium bicarbonate, it will as well as the water loss is also seen. Okay, and it is the weakest it has the weakest diuretic effect because of the most of the sodium lost at the early stage of the early stage of the this process, like proximal tubule, which is reclaimed further down the renal tubule. So like when the drug, sodium is reabsorbed over here 65 to 70%. So this has the weakest diuretic effect because the other the sodium is reabsorbed in the other part of the this one, renal tubules. Okay. So its continuation of the carbonic anhydrase inhibitor is here. So it increases the delivery of sodium to the collecting duct. This one is the collecting duct. Okay. This one is the collecting duct. This is the descending loop of Henle. Okay. This is the ascending loop of Henle, and this is the early DCT. This is the late DCT, and this one is the collecting duct. Okay. So it increases the sodium to the collecting duct. Further, it increases the reabsorption through epithelial sodium channels. Understood? So in exchange of increasing potassium loss, that is like it leads to hypokalemia. The main side effect of carbonic anhydrase inhibitor is hypokalemia. Okay. So as well, the loss of bicarbonate is seen, which affects the acid-base balance. That is, metabolic acidosis is the second. This one is the first side effect. This one is the second side effect. Okay. So and it is rarely prescribed for cardiovascular diseases because of the abnormal heart rhythms and all. Because hypokalemia is there will be abnormal heart rhythms. Okay. So it is for the use for glaucoma and metabolic acidosis. Since this one is acidosis is the side effect, so again it is used for the metabolic acidosis. So the second one is osmotic diuretic. So I explained like proximal tubule, carbonic anhydrase inhibitor acts here. So now osmotic diuretic, even this is the weak diuretic. Okay. The first drug is mannitol, isosorbate and glycerol. The site of action is proximal tubule and descending loop of Henle. I said proximal tubule and descending loop of Henle. Okay, osmotic diuretic acts over here and here. So mechanism is inhibitors of sodium water reabsorption, promotes water loss directly through osmosis. Okay. So being filtered without reabsorption, mannitol stays in renal tubule. So mannitol doesn't reabsorb back to the blood, or like there is no reabsorption of mannitol. Okay, so because of that reason, it promotes mostly the water loss from the urine. So being filtered without reabsorption, mannitol stays in the renal tubule. So it stays in the renal tubule. Okay, I said like osmotic diuretics acts on the descending loop of Henle. So in the renal tubules only the mannitol stays. Okay, and which creates an increased osmolality, which attracts water by osmosis. As I said, like more water loss is there, and it is not preferred in, mostly it is not preferred in edema because of its initial presence in circulation, like the excess fluid volume. Okay, and it is effective in lowering intracranial pressure, like in head injury and all. Mostly in cerebral edema they will use though, because I said like usually it's not used in edema, but in cerebral edema they are using because of the lowering, it lowers the intracranial pressure in head injuries patients. Okay, so the third one is loop diuretics. Loop diuretics acts on the ascending loop of Henle. Okay, so the first drug is furosemide, torsemide, bumetanide, ethacrynic acid, azosemide, and further is there. So the site of action, as I said, thick ascending limb of loop of Henle. Okay, and the mechanism is inhibitors of sodium, potassium, and chlorine co-transport. So it is a powerful diuretic. As we have seen the hospital setup and all, mostly they will be using loop diuretics. Okay, so it is a powerful diuretics because the drugs gets accumulated over here. Okay, mostly the sodium gets accumulated over here, because you know, like even in heart and all, when you will study like how it goes and pushes the blood back to the body, that needs more this pressure and all. No, it's similar, it's similar. Okay, so mechanism, inhibitors of sodium, potassium, chlorine co-transport, powerful diuretics. It reabsorbs large share of sodium, as I said just now, reabsorbs large share of sodium and is responsible for osmolarity gradient in medulla that enables the collecting duct to concentrate urine. Okay, and the side effects is hypokalemia, hypomagnesemia, hypouricemia, and ototoxicity. Okay, it also decreases, as I said, it also decreases the calcium and magnesium losses seen. Okay, in the loop diuretics. Okay, now loop diuretics is over. Now we'll come to thiazide diuretics. Okay, the drugs is hydrochlorothiazide, hydroflumethiazides, chlorothiazide, and this is thiazide-like diuretic. This is benzodiazines. Okay, so thiazide-like diuretics includes chlorothalidone, metolazone, zipamide, indapamide, and the site of action is early DCT, early distal tubule. Yeah. And then mechanism is inhibits the sodium chlorine co-transport. Okay, since I said like sodium here, it gets reabsorbed in 65 to 70% in the proximal tubule. In the loop of Henle, it accumulates up to 25%. In early DCT, it accumulates up to 5%, and in collecting duct less than 5%. So that explains this thing. So has a vasodilatory effect. Okay, has a vasodilatory effect. The thiazide diuretics has that vasodilatory effect. Is the first line treatment for hypertension and heart failure. Okay, so unlike other loop diuretics, thiazides also decreases the calcium loss in urine. Okay, fine now. So let's come to the potassium sparing diuretics. I have one more thing. Oh yeah, so metolazone is the superior to the other thiazides. Metolazone is superior to other thiazides, and due to the additional inhibition of the proximal tubule function. Okay, and even the loop diuretics, this one is more efficacious. The further when I'll explain the pharmacokinetics and doses, this thing I'll explain about those things. So yeah, this is more efficacious. Torsemide is more efficacious. Okay, yeah. Then let's come to the potassium sparing diuretics. The first drug is spironolactone, eplerenone, and amiloride and trimterene. Okay, the site of action is late distal convoluted tubule and collecting duct. I say potassium sparing diuretics acts on the collecting duct and late distal convoluted tubule. Okay, so the mechanism is inhibition of sodium reabsorption and potassium secretion. Okay, So sodium reabsorbs through the epithelial sodium channels, that is ENAC, and then the sodium and potassium pump in exchange for sodium loss, potassium loss. Okay. So both ENAC, that is epithelial sodium channels, and this sodium potassium pump are induced by aldosterone. Okay. So potassium sparing causes no increase in potassium loss, unlike the other diuretics. I'll say it again, potassium sparing causes no increase in the potassium loss, okay, unlike the other diuretics. So instead they reduce the potassium loss because there is decrease in sodium reabsorption. Are you getting? Yeah, it decreases the sodium reabsorption. Further, it decreases the electrogenic exchange of potassium. Okay. So because of the collecting duct reabsorbs the small amount of sodium, so it has the mild diuretic effect. Understood? So it is used in the to prevent the hypokalemia, and side effects includes gynecomastia, metabolic acidosis, and hyperkalemia. So gynecomastia is seen because the mechanism is decrease in the testosterone. Okay, seen in the male, gynecomastia is seen. So now let me come to the pathogenesis of ascites. I'll first explain the pathogenesis of ascites, and I'll explain approach to use of the diuretics in the ascites with the patient of cirrhosis. So when there is cirrhosis, when there is a presence of cirrhosis and portal hypertension, which will lead to vasodilatation. Okay, this part is really important. Please understand it. When there is a presence of cirrhosis, liver cirrhosis is there, and portal hypertension is there. Okay, that will lead to vasodilatation. And because of vasodilatation, vasodilatation is seen in systemic and splanchnic circulation. Splanchnic circulation is like there is a blood circulation in liver, this GI, these things and all. But there is a vasoconstriction in the renal circulation. Understood? Like vasodilatation in systemic and splanchnic circulation, and vasoconstriction in the renal circulation. So when the alteration in the renal autoregulation, I told like vasoconstriction is seen in the renal circulation, then there is an alteration in the renal autoregulation as well as reduction in the functional liver cell mass, cirrhosis is there, okay, and development of cirrhotic cardiomyopathy is seen. Explain the approach to use the diuretics in the treatment of ascites in patient with cirrhosis, okay, liver cirrhosis is there. So first thing is there that we need to see if the patient has come with the first visit for the ascitic tap fluid and all, okay. So in those patients we need to monitor the salt intake, that should be 5 to 6.5 grams per day, okay. Salt intake should be 5 to 6.5 gram per day, and further we need to see, like we need to start with the first line treatment, that is spironolactone in around 100 mg, which will further go to initial this one dose, which will go around till 400 mg, okay. Maximum dose is 400 mg, and if suboptimal dose is seen, then we need to see, we need to add the furosemide loop diuretics, furosemide around 40 mg, and the maximum dose is 160 mg for this thing, okay, ascitic thing. And after, like again, if the patient has come with the complaints of repeated ascites, then we need to just start the therapy with spironolactone 100 mg, okay, and furosemide, including furosemide 40 mg. We should not wait for the suboptimal dose response and all. We don't need to see. We just need to add spironolactone as well as furosemide. Okay, fine. And then to see the diuretic response. Now, after this, to see the diuretic response, if the patient has edema, okay, if the patient has please try to understand this. If the patient has edema, to see the diuretic response, we need to check the patient has weight loss of 1 kg per day. 1 kg weight loss per day if the patient has edema, okay. And if the patient has no edema, then the weight loss is around 0.5 kg per day, okay, understood. So further after that we'll check the diuretics adverse effects and all, like hypokalemia, what I said, like metabolic acidosis, this all things we need to check, and we need to again monitor the salt intake. Okay, if again the salt intake is up and down or something like that, we need to start with the therapy again. It's like repeated cycle. And if the ascites is managed, then the diuretic dose should be reduced to the lowest as possible. Okay. So for now this much, to be continued. I'll explain in the pharmacokinetics, doses, and for pathogenesis of the approach to use the diuretics in heart failure patients in the next class, as well as anti-diuretics I'll explain in the next class. Thank you.